Hello, today I want to talk about governance. Governance is a complicated concept for many of us because we tend to confuse it with government. But it is a critical element to our understanding of policy. So I will talk about policy and governance. I will also talk about some issues related to governance questions. There are various approaches to governance. I will therefore have to deal with some theories on governance issues, and I will present a few cases. So the first case that I want to discuss is this ad in the newspaper from mostly Western Australia. The Medical Association of Western Australia published this ad saying statins, trust your doctor's advice. They published this ad because Catalyst, a program on ABC, the national broadcaster, said that a lot of people were unnecessarily prescribed statins. Statins reduce your cholesterol. The policy is very clear. Statins should only be prescribed in cases where people have very high hereditary levels of cholesterol, and statins thereby can reduce the risk that is associated with that. Catalyst said that a lot of people unnecessarily got these drugs and that there were some risks associated with taking statins. So contrary to the policy, the doctors put this in the newspaper, and of course statin use went up again with a number of people that before were very concerned about using statins that thought, well, let's trust my doctor's advice and go for it. This typically is an issue of governance, and in the remainder of my presentation today, you will discover how this is governance, because this is clearly not something that has to do with public policy. An issue that has to do with public policy plays out about 50 years ago here. These are the Snowy Mountains. Just after the war, the Second World War, the federal government decided that it would be a good idea to have something called the Snowy Mountains scheme, where they would generate a lot of hydro power from turbines that are built into huge dams that would contain artificial lakes. So hydropower would free the country of 1/3 of its need for oil. The Snowy scheme would also allow for irrigation, because a lot of rivers, for instance the Snowy River, would be redirected to be able to irrigate arid lands or lands that had trouble to be irrigated. Now, the problem here was that these Snowy Mountains, most of them, are in fact in New South Wales. And the federal government knew that if they would leave this to New South Wales, to the state government of New South Wales, nothing would ever happen, because the government of New South Wales just after the war had all sorts of other problems to consider. So someone came up with a clever solution to say, no, it is important to have these lakes and those dams and to have that all in the Snowy Mountains for defense reasons, because this would be something that would be very hard to destroy by any enemy attack. So they, rather than constructing the policy issue as an irrigation and power issue, they constructed the issue as a defense issue. And because defense is one of the few Commonwealth issues that is very clear-cut, they could say, well, the Snowy scheme has to be a Commonwealth scheme. Again, this is a very clever use of issues around governance. It had very little to do with formal policy making. It had very little to do with framing the issue. It really had to do with considering where the solution for a problem would best lay. So what is governance? Well, there's a couple of perspectives on this. This is what David McQueen said in the Global Handbook on Non-Communicable Disease and Health Promotion. And this book was published in 2013 if you want to have a look at it. McQueen writes, in present-day public health, the term governance has become widely used in recent years. However, there are many definitions of governance, samples of which can be found in many documents. In addition, discussions and definitions continue to abound. Whatever definition one wishes to work with, the key consideration is that the word government is a noun and is an institutional word, of which more later in the chapter. Governance is more of a verbal concept. It is what a government or a government-type entity does. It might be a geopolitical government, nation-state, a corporate government, a business entity, a socio-political government, tribe, family, or any number of different kinds of government, but governance is the physical exercise of management power and policy. The term government is also used more abstractly as a synonym for governance, as in the phrase peace, order, and good government, found in section 91 of the 1867 Canadian Constitution Act, as well in a number of Commonwealth country documents, like Australia. In any case, most definitions deal with the process by which decisions are made, the exercise of political authority, how institutions collaborate and delegate resources, and, in other words, the management of power by institutions. From its very beginning, public health has been involved with governance, and it remains a key area for public health research and understanding. So, how does that relate to Australia? In our national reforms, of which we have seen quite a few in recent years, there are quite a few examples of governance issues that have been considered. In existing policy coordination, these are a few aspects or bodies where governance actually plays out. The AHMC is the Australian Health Ministers Conference, which is the conference of all the state and territory ministers of health. And it is a subcommittee of COAG, the Council of Australian Governments. For the AHMC, you have the AMAC, and that is the Australian Health Ministers Advisory Council. And they talk about coordination of policy issues related to health between the different states and territories. This necessarily has to involve the NHMRC, the Medical Research Council, and the Australian Institute for Health and Welfare. They provide insights in policy systems, policy success, and policy failure. So there's the COAG Health Working Group that extends beyond the AHMC, that has the premiers, the departments, and the treasuries of all the different states and territories that also talk about health. And they also need to talk about governance, how they deal with management of issues, the framing of problems, etc., etc. Then, of course, there's national reform dealing with governance that deals with other things, with recent structural changes. For instance, local hospital networks, a recent development around Medicare locals, how to organize primary care at a local level. And there's issues around the National Pricing Authority, the National Performance Authority, etc. One aspect of governance that is quite important for the public health field is the Australian National Preventive Health Agency, which falls under federal legislation but has its own board and is a statutory agency that is supposed to drive preventive health in the nation. Now, all of those things happen, and all of those things try to organize the health system in better ways, not just through legislation and policy, but also through a range of other aspects in managing relations, etc. So how would you change government for better outcomes? How would you modify the governance of the Australian health system? Well, tricky question. First of all, as McQueen said in his statement, government is not the same as governance. Although there is a primacy of government in public health policy, there are other actors that need to be involved in running the health system and public health policy outcomes. Therefore, there's an evolving context and different approaches to governance. New insights and new developments in how we see the world frame what we can do and what we cannot do in running the system. I will come to talk about nodal governance, where you look at different actors, different stakeholders, and how they connect with each other and what you can do at the nodes between those different stakeholders. I will also talk about multi-level governance, which adds a dimension of different levels to just the nodes in the nodal governance idea. And I will illustrate that on the basis of a number of cases. Another issue that we need to consider is whether public health policy really is a government concern. And maybe it's a good idea to just go back to the original and authoritative definition of public health. Public health is the science and art of preventing disease, prolonging life, and promoting mental and physical health and efficiency through the organized community efforts for the sanitation of the environment, the control of communicable infections, the education of the individual in personal hygiene, the organization of medical and nursing services for the early diagnosis and preventive treatment of disease, and the development of social machinery to ensure to every individual a standard of living adequate for the maintenance of health, so organizing these benefits as to enable every citizen to realize his birthright of health and longevity. This is a definition proposed in 1923 by Winslow, and it has been the foundation for a WHO definition of public health and the WHO definition of health generally. But when we look at this, we don't see a focus on the state or a focus on government. It says here it is the organized community efforts and the development of social machinery. So governance really is very well reflected in this extended definition of public health. And clearly, governments play very important roles in this. So we would see public health as the organized effort by society. And that means a stewardship role of the government. Government does have the power and the authority to organize that effort by society. Also, we find public health a public good. And where markets fail, for instance, health insurance, in the United States or in Australia, it is good for government to step in and regulate things. Also, government has a unique role in that it can have a coercive position. It can force people to do certain things. So they can make rules, laws, regulation. And that is the core of health protection. Sanitation, for instance, and all sorts of codes and legislation on how to deal with waste, how to deal with sewage systems, is something that is typically in the hands of government. And government clearly has a redistributive power. They can tax people, organizations, and they can then redistribute the income from that taxation for the better of people. And it should be able to reduce health inequalities by doing that. Take away where it can be missed and invest in where it would have a good outcome. Recently, we've seen a new development in government responses to the needs of society to be organized well. And you may wonder what this is, and these are planes in Vietnam. Some of the government responses to governance in health and well-being is a mix of proactive and reactive responses. On the one hand, government has the role to anticipate what is happening in society and make policy. On the other hand, there are things that you can't foresee, and therefore you have to be reactive. And whether that is done with great efficiency is another question. For instance, there is a very long distance from science to policy. For instance, the insights in the harmful nature of tobacco and asbestos took years to establish. We recently celebrated 50 years of the clear epidemiology of the harmful effects of tobacco, and we are still struggling with making policy for tobacco control. There's also a long distance between policy and evidence. For instance, the rebate for private health fund membership here in Australia. Is there real evidence that makes for a more equitable distribution of access to healthcare? We still don't really know, although the evidence seems to suggest that evidence is lacking. Government also very often says, well, there's something wrong here. Epidemiologists would call that, use the precautionary principle and say something's wrong here. But government says, no, we need more studies, we need more reviews, we need more committees, often to stave off responsibility, which is also an aspect of governance. For instance, in the use of Agent Orange, and that's the photo that you see in the background, Australian and American troops became exposed and leave alone, of course, the Vietnamese population. People got exposed to Agent Orange, which was a pesticide, a herbicide, to defoliate, take away the leaves of the forests in Vietnam. And the idea was that without foliage, without leaves on trees, the Americans would be able to see more easily who was hiding in the forest. But those herbicides contain dioxin, and dioxin is a highly toxic material, highly toxic chemical, and we now know that Agent Orange, dioxin, has caused birth deformities and really terrible issues in people that have been exposed to it. And still, both in the United States and in Australia, there are some ongoing efforts to say, well, we need to look better into this. We need to consider what the bad aspects of Agent Orange are. And that's a governance issue. It has very little to do with actual policy making based on evidence or government roles. It is something that exploits the opportunities that governance gives us. And then there's, of course, the craze of the day, where you have short-term orientations, risk aversion. What the media says is what you need to respond to. And then, of course, there's the slightly wacky nature of democracy. Some people are better able to get across what their message is than others. And you need to have a vote on it. There's never real full consensus. So government responses to governance in health policy tend to be a bit fuzzy. Another maybe complicating aspect of this discourse is the evolving nature of public governance. We see all over the world that there is something called public-private partnerships, and public-private partnerships are a reflection of the new public management idea. And that is the idea that governments should act more as corporations. Some people would call this the neo-corporatist approach. In new public management, governments have a focus on results, on output and outcome-based funding. You only pay for things if you can show that there is a result. And it is driven by performance-based evaluation. It is an ideological shift, neoliberal, neo-corporatist, toward the market. The idea is that the market can regulate best what is happening. Governments are no longer rowing, do stuff all on their own. They steer. They are the directors of the bigger scheme. And the idea is to let managers manage. And in Britain, for instance, the public health system has separated the purchasers and the providers of healthcare elements. where people have to buy the provision of certain goods and others can provide those goods. And the idea is that you create a market, and in that market, the best choices will be made through economic incentives and economic reasoning. But this has led to hollowing out of the state. The state is no longer the most important actor in the game of government or governance. There's a move towards networked arrangements between the state, the market, and civil society, communities, industry, etc. It means for government that there is a degree of devolution of financial and political risk. You can blame others. You can say, look, this is not our role anymore. Our role is to steer. Our role is not to deliver. It does increase complexities in society, and that requires more collective capacity to get things done without solely the power of government. It needs coordination mechanisms that include government, but are not only limited to government. And that makes things a little bit more complex. Back to concepts of governance in order to appreciate this complexity a little bit more. In corporate governance, you would talk about governance as a system of control and authority. Who does what and who does have the authority to control what? The World Bank says, well, governance is the manner with which power is exercised in the management of a country's economic and social resources. Williamson says, no, it's the active actions and means to promote collective action and deliver collective solutions. Colbatch, and we've heard about him earlier in his definition about policy, says that governance is the process of continuing interaction among participants inside and outside the formal structures of government, bringing to bear a diversity of frameworks through which matters are seen to need attention and responses evaluated. So it's about coordination and interaction. Rhodes, a very important scholar in network governance, says, no, governance is about self-organizing inter-organizational networks that are interdependent, and interdependence is a very important word to remember when you talk about governance. Scott Burris says, well, governance is simply how we manage courses of events in complex social systems. When we look at all of these aspects of governance, we can see a number of key features as summarized by Stoker. It's about institutions and actors within and beyond government. And we need to realize that when we talk about public health policy, that we cannot restrict ourselves solely to the role of government. Governance talks about a balance of rights and responsibilities between those institutions and actors that are within and beyond government. There is talk clearly of a dependence in power between those institutions. And in new public management visions, there should be business rules for relationship management. And we come to talk about that later, about relationship management. This is one of the aspects of multi-level governance. In terms of chaos theory, the idea is that governance would lead to self-governing networks of actors. Actors themselves shape the inputs and outputs of what they're doing around certain issues. And the capacity to get things done is not dependent on hierarchical control. It's no longer that the government directs the actors and says, you do this, you do that, you get this, you get that. How things get done depends on complex negotiations between those actors in their networks. So there's a shift from authoritative direction to a subordinate bureaucracy to negotiate among stakeholders. There in fact is a literature around street-level bureaucracies where the operators in the system actually create the rules, the governance, how to deal with complexity and how to make sense of the world. Nodal governance relates to the management of nodes within complex social systems. And the same Scott Burris said, well, this is about cajoling, coercing, or otherwise moving those they wish to govern to comply with their direction. So it is how certain actors try to manipulate or coerce or move in certain directions those others that need to play a role in the nodal governance perspectives. Nodal governance harmonizes the interests across a constellation of institutions through various tools of influence and constraints on governance. So you try to show that doing a certain thing is better for your own interest, for those of your target group, of your mission, of your purchaser-provider split, etc., etc. It is about framing issues in such a way that there's a shared understanding of the problem and a shared appreciation of how groups of partners in a network can establish better ways of dealing with reality. And together they then shape policy. Another perspective is looking at particular levels of government and different roles actors in those different levels of governance could play. And in this graph, you actually see those different levels. It is the top level, the medium level, the lower level, and there are vertically a number of ways of looking at this. Hill and Hoop actually talked about different forms of governance: constitutive governance, core beliefs about how things work in society, a constitution, core rules. Directive governance is this is how we do things here, and operational governance is the actual rules of the bureaucracy and how we deal with each other. And then there are three levels at the system level, for instance, the global system or the national system. There's organizational level aspects. How does this organization deal with governance issues? And there are individual level considerations. How do individuals within the bureaucracy or within the complex network around governance develop their professional norms? Or how do they apply the rules that are set at a higher level? How do you manage contacts? Is it just telling people what to do, or do you sit around the table to discuss how things happen in your relationship? So Hill and Hoop actually show that this is a very complex system, but you can make sense of it through establishing different perspectives on governance, constitutive, directive, and operational, and distinguishing between the different levels of governance. And I will come to talk about this later when I discuss the global health system. When we look at the public health system, what are the building blocks? Well, these are the different things that we do in public health. We have to consider regulation. We consider information as a very important communicative strategy or a tool to get public health outputs. There's the organization of programs that involves that multitude of actors within and outside governments. And we protect and promote health, and that is kind of an output system. Ultimately, it all costs money, and therefore we have to arrange financing and payment for performance. The relations between those different building blocks are fairly clear. How information is created depends on how we have regulated information provision and how we pay for that. How we protect and promote health depends on the organization of programs, financing, and regulation. And of course, there are some feedback loops in this system. So when we look at the delivery system and how this works, is that we have a number of service strategies. In the left column here, health protection, health promotion, preventive services, screening and early detection and rehab and palliation. And we can look at the different levels of prevention: primary, secondary, and tertiary. Primary is prevention before it happens. Secondary is prevention when you know it's going to happen, and tertiary is prevention after it has happened. The focus of concern, therefore, across those different levels is different. We look at health and suspected illness, and we look at illness and disability. The target groups are fairly different, from the wider community in health protection, through focus on particular population groups, to individuals. Preventive services typically are aimed at individuals, as is screening and early detection, although it can have a population health approach, but it's aimed at identifying individuals that are at risk. And similarly for rehab and palliation, this is typically focused at individuals. And you can see that the providers in doing this follow suit. For the community-wide delivery of public health goods, government must take, or often takes, center stage. But the further down you go into this most right column, you see that there are more actors involved. The community, health services, GPs, hospitals, health services and other providers. And the idea in multi-level governance or nodal governance is that the more complex the system gets, the more complex the network management, or the more complex the allocation of resources and responsibilities across the different levels and between the different actors in the system becomes. So, what's the governance model then? Well, these are the different elements: policy and investment, advocacy, analysis and capacity building, and action in the public health system. We need to have policy, we need to have action, we need to advocate for these things, and we need to analyze and build capacity. And of course, the latter thing is what we're doing here at La Trobe. We're not making policy, we're not investing in the system in a way. Although we may interface with those things. So who are the actors? The actors in each of those systems are, for policy and investment, jurisdictional authorities and the Medical and Research Council. For analysis and capacity building, it's universities, research institutes, and professional organizations. The action field is run by governments, NGOs, health service providers, which are public and private, and of course a degree of university investment as well, because we want to evaluate action. And in terms of advocacy, we are typically looking at consumer and professional organizations, other NGOs. Think of Amnesty International when we talk about human rights, for instance, health service providers, and again, those teaching and research institutions. Now, the question is, if this is so complex, we need to generate a degree of governance coherence. We need to be all on the same page if we want to do this right. So, my first case that I want to explore in depth is about prevention. There was a National Public Health Partnership, but that's been rearranged into different committees for health protection and health development across the states, across the territories, with a degree of coordination through the Public Health Association, the Health Promotion Association, etc. There is a National Preventive Health Agency, and we would hope, of course, that they have that coordinating role, but they're under Commonwealth control and only focus on 3 priority areas: tobacco, alcohol, and obesity. So what if we want to talk about the governance of healthy cities, of healthy communities, which is a government program? Healthier Communities is a government. What does the National Preventive Health Agency do if they are only supposed to look at tobacco, alcohol, and obesity? Those systems level interventions in building healthier communities may fall by the wayside. How does that happen? There is something called the National Preventive Partnership payments, and they focus on healthy children, healthy workplaces, and communities, not healthy communities. But there is a payment structure that allows for funding of these initiatives. Whether that all is coordinated whether that addresses issues of social determinants of health and health equity is another question. And when you look at the literature that's emerging here in Australia, equity and social determinants of health are issues that are not comprehensively addressed. There is a fragmentation of public health groups, and I'm not going to give the explanation of all of these acronyms, but because that could be good homework, or we could discuss that in our workshop. But these people are not always on the same page. These different groups do different things in Australian society. There has been a joint conference between these groups, but is a conference enough? Every 3 years they meet in a joint conference. Is that establishing coherence, and is that good enough to run public health governance systems? And then, of course, there is a bit of what you could call pollution through a lot of different advocacy groups that are focused on very particular special issues. 2 years ago, I wrote a book about this, Democratizing Health, looking at patient groups in the policy system. And we found that they are not able, maybe not willing, to collaborate with each other to have an overall coherent governance perspective on the public health system. They typically want to advocate for their own little thing, heart disease, cancer, asthma, diabetes, etc. Although there are exceptions. The Heart Foundation has been doing some fantastic work around healthy places. The Cancer Foundation typically is very supportive of systems level interventions like taxation, etc. So there are some good examples, but typically the multitude of small-scale special interest groups gets in the way of coordinating the public health effort. And I should say that's not just the case in Australia, that is the case in most countries. And it may be something that, again, we could discuss in our workshop. Now, my second case deals with this: global health. There are many manifestations of global health: refugees, agriculture, mining, brain drain, obesity, violence, economics, and you would quite quickly agree with me, I guess, that governance in that complex global environment is really a big issue. So, what are we looking at when we talk about global health? Well, in the past, people would have thought that the world was an easy concept. There were a few superpowers that ran their business through their colonies. But the Second World War threw a spanner in the wheel. And after World War II, a number of agencies were established with the ideal vision to create governance and good governance, coherence in governance around the world, mostly to prevent war in the future, but also to work toward joint economic development. So the United Nations were established as a consequence to World Health Organization. The Bretton Woods institutions, those are institutions that make for financial stability: the IMF, the International Monetary Fund, the World Bank, and the regional development banks, and some major philanthropies that already existed. The Ford Foundation, the Rockefeller Foundation, continue to play a role in that governance structure. And then you would have bilateral aid that grew substantially after the Second World War. For instance, AusAid or USAID. But in the late 20th century, all of that started to break down, and we started to get something that has become known as the post-Westphalian world order. The Westphalian world order was established in the 17th century through the Treaty of Westphalia. And that created nation states. And the idea of the nation state is that they have great autonomy and authority, and within the boundaries of the nation state, a government is at complete liberty to do what you're supposed to do, and no one else can interfere in that autonomous running of a country. The post-Westphalian world order suggests that there are other actors that do interfere in what happens within nation states. And a very clear example of that is multinational industry, who move capital and move production, move facilities between nation states. And in some cases, the economies of big multinational corporations are bigger than the economies of a small country. So they have their own sources of power and they can control things. There are other actors in this game as well, and I will come to talk about that, because there's all these new entities that want to play a role in global health governance. Public-private partnerships, large international NGOs, for instance, the Clinton Foundation, the Bill and Melinda Gates Foundation. There are UNAIDS, the Global Fund, Gavi, the Soros Foundation. They all bring together a host of different types of actors in order to promote public health around the world. That has meant that the balance has shifted between what was originally an instrument of the Westphalian world, the World Health Organization, and the World Bank and bilateral aid. They play less of a role in the new world order, than those old agencies. So there's a new global health landscape. Some people would call this a new global health architecture. One of the things that has happened is that there's a distortion of funding, whereas in the Alma Ata Declaration on Public Health in 1978, the argument was for better integration horizontally, to have primary health care focused on access to basic services through the full acceptability of those services to all. Vertical programs look at just the provision of sanitation, just the provision of vaccines, just the provision of essential drugs, for instance. And integration between those different vertical programs has become a challenge. The authority of the World Health Organization as the one representative body of the world has been undermined. All these other organizations want to do their own things. And WHO currently is in the process of trying to regain that authority. For instance, when we look at non-communicable disease programs, WHO has established a global coordination mechanism to coordinate between state and non-state actors and across the United Nations system. But that is certainly not easy. There are these days very complex processes for resource mobilization and management. And some of these processes are not very transparent. How is the money that the Bill and Melinda Gates Foundation disseminate, how is that controlled? On the basis of what priority? Unclear how that happens. Within the World Health Organization, there's a lot of competition for extra budgetary support. The organization has its own budget, membership dues, but a lot of countries actually give extra money to do particular things. How does that happen? Who gets the extra money for what purpose? And we can discuss some examples of that when we meet, either in face-to-face or in the cloud. There clearly is therefore competition for dominance of policy agendas. What is more important? Poverty reduction, equity? Which of the Millennium Development Goals should take priority, and where are we putting our money? All of this also has meant that there's an emergence of new centers for global health. A lot of people say all of a sudden we're doing global health. Old actors that did international health are now competing for the agenda-setting role in global health. And if you enroll in international health policy next semester, we will dig to the depth of the issues here and discuss how this actually is problematic. Rather than thinking, well, the more the better. in this case, the more the better means added complexity and added trouble in organizing things. We wrote ourselves a definition about global health, and that is not the same as international health, where countries collaborate for the betterment of health of typically populations in warm climates. We looked at a definition of global health that looks at health being determined and constructed by people and their institution at every local level of human activity. And we acknowledge that there are no longer predetermined institutional arrangements for the governance of health at the global level. There is no standard way of organizing global, local health. In the past it was simple. The World Health Organization or countries working together through other channels. Now it's a fuzzy and chaotic enterprise. In fact, we produced in the Clavier and de Leeuw book on health promotion and the policy process, we produced a research agenda using the Hill and Hoop system of multi-level governance. So we looked at constitutive governance, we looked at directive governance, and we looked at operational governance, and we asked questions at the system level, at the organizational level, and at the individual level. What happens? What question could we ask in terms of research? And what kind of theory could we apply to that question in order to not just explain that issues arise, but also how they arise and how they can be resolved? So these, and on the PDF that you can download, this is probably better visible. I'm not going to enlarge any of this in this video. But you can see that there's a multitude of different perspectives and different actors that all should be investigated if we understand global health better. You might think that there's kind of a cycle of global health governance that goes from the local level through the global level. And you have the level of governance that goes upwards in a fairly romantic idea. People determine what they want. They have their democratic views and possibilities to let their voice to be heard. And that goes up to the global level. Then there is, between all the different organizations at that level, institutional and governance arrangement. Who does what, for what purpose. And then it goes down again to deliver the goods to the local level. Now, if we look at the different actors, which I already mentioned, we have actors at the global level, WHO, Bill and Melinda Gates Foundation, but also free trade arrangements between countries. And the flag you see here is between Canada, the United States, and Mexico. You have these public-private partnerships, the Gavi Alliance, which is on vaccines. But also big multinational actors, Shell Oil. Then there are actors at the national level, and they're the traditional Westphalian nation states. And who guesses the flags of these countries correctly gets a bonus point, obviously. And then at the state and provincial level, in federal countries like the United States or India or Australia, there is the delivery, the framing of policy issues as well. So these are some states at the subnational level, like Quebec, that want to pursue their own goals in the delivery of health and public health. And then, of course, there is the local level, your local council where you live. And sometimes local councils, local governments organize themselves. They come together. For instance, the local governments for sustainability, ICLE, or healthy cities. What complicates matters here is that there are some less usual suspects in this scheme. These, because they play a role at different levels. They don't just play a role at the global level, they also play a role at the local level. And that's why I explicitly want to talk about global health and not global health. So governance is about how we manage relationships between actors in complex environments that transcend the nation state. In wrapping up, we can say that public policy is about iterative processes that are historically layered and path-dependent and marked by punctuated evolution. But they're always characterized by competing interests. They are organized in certain ways, but there's always structural determinants unique for each country or unique for the level that you're looking at. Institutions are embedded within the political economy. How they get their money, how they spend their money, and with whom they spend their money or resources or knowledge. There is definitely scope for agency, behavior of actors. Policy entrepreneurs recognize openings and creative spaces for influences. When we talk about governance, the multi-level perspective clearly says that individuals can play an important role in shaping governance arrangements. Governance really, and we come to the final bottom line, governance is a mediating process. It talks about the rules of the game, and we can shift the rules of the game. And I will come to talk about that much later in this semester, about how you shape evidence to shape the rules of the game. That is a bottom line, but there's also a question as a bottom line. If we talk about governance as a mediating process where people play a role, but institutions are embedded in the political economy, how do we ensure that governance is taking health into account, is for health, and really assures participation from the less powerful in order to address issues of equity and social determinants of health? That really is an issue that we are going to discuss in the remainder of this semester. See you at the next video lecture.